Good afternoon. Welcome to the Heritage Foundation and our Lewis Lehrman Auditorium. We, of course, welcome those who join us on our heritage.org website on all of these occasions. I would ask everyone here in-house to be so kind to do a courtesy check that cell phones have been muted. It's always appreciated. Thank you, Ed. And for those online, we'll be glad to receive questions or comments at any time, simply addressing them to us at speaker@heritage.org. And we will, of course, post the program following the presentation on the Heritage homepage for everyone's future reference. Introducing our speaker this morning is Ed Hazelmeyer, who is Senior Research Fellow for Health Policy Studies here at Heritage. His expertise in health care policy and markets includes healthcare tax policy, Medicare, Medicaid, foreign health systems, pharmaceuticals, as well as health care price supports. He joined Heritage in 2005. He had previously been a health policy consultant, and he has also served as Director of Health Policy at Pfizer's Corporate Strategic Planning and Policy Division. He originally came to Heritage, I won't say how many years ago, as the think tank's first policy analyst on healthcare, and just never left in a way, did you, Ed?
I came back.
Yes. Thank you all, and welcome, Ed, for our program.
Well, thank you, John. Unfortunately, you made my introduction longer than our speakers, which is not a good idea. We have this month, as many of you I'm sure are aware, marking the 50th anniversary of then President Lyndon Johnson signing into law legislation that created the Medicare and Medicaid programs back in 1965 at the end of July of that year. And so a great deal of attention has been focused on those two programs because of the half-century mark being reached. Some folks celebrate those. I think what we're looking to do, though, is maybe reflect on the experience we've seen over the last 50 years and what lessons it has for the future. And to that end, I'm pleased to have our guest speaker here today. You know, Medicare and Medicaid, I think, are symptoms of the idea that people often have that, well, if we have a big problem, we need to have somebody big, and that often turns out to be the government, go and solve it. I notice people in the audience with their phones, which now, of course, have cameras in them. That's okay. You can use them. And I would simply point out that those didn't come from a big government program. Those came from actually what started out as, in many cases, for the various components of those phones, little companies by a few people with a few ideas in garages, some of which are now very large. But they got that way by being innovative. And that's not the path that we've seen in large government programs, particularly Medicare, as we're going to discuss today. Our guest speaker, David Hogberg, has a PhD from political science from the University of Iowa, is a senior research fellow at the National Center for Public Policy Research, and previously wrote for Investors Business Daily and has covered healthcare a considerable amount. As he was saying before we got up here, he said, you know, if I had it to do over again, I probably wouldn't have started out writing a book on Medicare as the first topic. I would have maybe taken something a little smaller as a starter. The problem with Medicare, and David, we'll get into some of these things. The problem with Medicare is that for all the benefits and the good that it's done, and it has, I mean, you can't spend trillions of dollars without achieving something positive. It is organized in a way that is not necessarily good for everybody and does not necessarily produce optimum results. And that's a cautionary tale, and it's also the place where we can start looking to learn lessons for the next 50 years on how do we take these very large programs, and this is one of the 3 or 4 largest in the entire federal government, and reform them in a way that is more responsive, like the personal phones that everyone is carrying today, to the needs of consumers and provide scope for innovation in meeting those needs in the marketplace. So with that, I shall step aside and, if you don't mind, watch from the audience, because I know you have a PowerPoint presentation, and David will present on what he has found about Medicare. Thank you.
Okay, I would just like to start by thanking John and the Heritage Foundation for putting this event together, and Ed, thank you for that very nice introduction. Thank you to the National Center for Public Policy Research for publishing my book, and I'd also like to thank my parents who are right back here and my lovely wife Laura who have come here today to provide moral support. And I also need to thank my cat Goose, who permitted me to leave the, basically to borrow his laser pointer today. So I want to say thank you, Goose. Alrighty, a couple of chapters here I will be talking about today, the various concepts. They are chapters 2, 3, I'll be pulling parts of them out of it, 2, 3, 5, 8, and 10. So let me just very briefly talk to you about some of the other chapters. The introduction, I will be taking a few concepts out of there, but in the introduction I also examine what's known as hospital-acquired infections. Somewhere between about 75 to 100,000 people die each year due to an infection that they pick up in the hospital. The problem with Medicare is that it not only pays for what, for whatever caused you to get into the hospital in the first place, it also pays the hospital to treat you for any infection that you pick up there, which, as you can probably guess, gives hospitals a big incentive, or lack of incentive rather, to take preventive measures to prevent hospital infections. Medicare has tried to crack down on that in recent years. As I look at in the chapter, though, it's not clear as to really how successful that's been. Number 4, the donut hole. Most of you have probably guessed by now that is about Medicare Part D, the prescription drug benefit. Part D has this very odd benefit design where right in the middle of it there is this hole where beneficiaries pay 100% of their drug costs. And Chapter 4 looks at how seniors fare when they hit the donut hole and why Congress designed Part D that way. Chapter 6 looks at overtreatment in Medicare. Medicare's price controls often overpay for certain procedures, causing doctors and others to overuse them at times, and that can put Medicare beneficiaries at greater risk for their health. I looked at colonoscopies. That is, I think, one area where Medicare achieves a lot of overuse. The other thing I look at in that chapter is something called the Dartmouth Atlas. If you've paid any attention to healthcare policy debates in the last 5 to 6 years, that has been an academic research group that was actually very influential in Obamacare, and I look at why I think a lot of their ideas are in fact wrong. Chapter 7 actually examines primary care physicians and why more of them are limiting their exposure to Medicare. Regarding the 2 physicians in that chapter, one is Dr. Juliet Madrigal-Dersch, and should you ever live in the Austin, Texas area, you would do well to have her as your family physician. The other one is Dr. John Slotowski from North Carolina, also a good doctor and also a bit of a character. When I interviewed him, he compared Obamacare to a stool sample. I was taken aback, and I said, "Why is that?" And he replied, "Well, it's like Nancy Pelosi said, you have to pass it to find out what's in it." And finally, Chapter 9 looks at how the American Hospital Association and the Federation of American Hospitals use Medicare to stifle the competition they face from smaller physician-owned specialty hospitals. Some of you may read Tim Carney in the Washington Examiner, who focuses heavily on crony capitalism. This was definitely a case of crony capitalism involving Medicare. Okay, now moving on. Just so that we're all on the same page, Medicare is, of course, the federal health care program for seniors over age 65 and the disabled. It includes Part A, which pays for hospital visits, skilled nursing facilities, and the like. There's Part B, which pays for physician visits and other outpatient care. There is a Part C, although we refer to that now as Medicare Advantage, where Medicare beneficiaries can get their benefits administered by a private insurance plan. And of course, there's Part D, which I've already mentioned, covers prescription drugs. Okay, who are Medicare's victims? Well, I define a victim in the book as a patient who has been physically or financially harmed by Medicare's policies. And I don't mean something that's minor. In the book, you'll find that most of the harm is actually pretty substantial. As for physicians, I define a physician as a victim if Medicare's policies have hampered his or her ability to provide quality treatment to his or her patients. Now, let me introduce you to two people who I'm going to talk about for the next few minutes. The first one is Sean Plomin here with his wife, Sherry Lynn. And I'll be talking about him because Sean's difficulties are part of a long-term problem with Medicare. The second on the right is Frank Alfisi, pictured there with his wife, Phyllis. I chose to focus on him because his problem is a more recent one with Medicare. Indeed, it is a problem that was in part created by Obamacare. All right, beginning with Sean. As a teenager, Sean came down with cancer in the upper part of his left leg. The femur had to be removed, and to try to save his leg, the surgeons took the bone in the back of his lower leg, the fibula, and put it where the femur is. The femur, of course, is built to hold the weight of the human body. The fibula, by contrast, is very thin bone. And when I interviewed Sean, he referred to it as a twig because it broke so often. He had a number of surgeries to try to fix it, which left him with a lot of scars and a great deal of pain in his leg. Now, in his early 20s, when he went on Social Security disability insurance, he applied for Medicare at about the same time. And when you're disabled and you apply for Medicare, in most cases you have to wait 2 years before you are allowed on the program. Now, at any given time, there are about 1.2 to 1.8 million people who are in the Medicare 2-year waiting period. And the last estimate I saw, about 16,000 people die each year while on the waiting period. I think there's a temptation to say, well, these people are sick, they're probably uninsured, they're not able to afford health care, and that's why they die. You have to actually be pretty careful with this statistic because, first off, a lot of the people who enter the 2-year waiting period are gravely ill. They could have gold-plated insurance and still pass away. The other thing is that most people in the waiting period, surprisingly enough, actually have some form of insurance, whether it's Medicaid or maybe insurance through your spouse or something of that sort. Only about 20 to 25% of people in the waiting period are uninsured at any one time. And I'll just make a quick note here. It's kind of hard to give a more general overview of what it's like to be in the waiting period and be uninsured because there's really just an overall lack of research on that issue. I'm not sure why, but it was just something that was frustrating to me as I was trying to research this particular chapter. All right, Sean Plomin was one of those who was uninsured during the waiting period. And he could not afford pain medication for his leg, and as he told it, he suffered from excruciating pain during that period. He described the scars on his legs as lighting up almost daily. To calm the pain, what he did is he drank, and as he put it with regard to alcohol, quote, the cheaper the better. Unfortunately for Sean, he suffered not 2 years in the waiting period, but actually 4 years. And we've never been able to figure out exactly how that happened. The reason is probably lost, as understandably Sean's memory about that time is a tad hazy. Once, though, he got on Medicare, he was able to get good pain medication, good treatment, and fortunately he got off the bottle rather quickly, so it does have something of a happy ending. Now, the 2-year waiting period has been in place since Congress allowed the disabled access to Medicare back in 1973. Congress has never really come close to either reducing it, let alone eliminating it. And perhaps the closest Congress has come was actually in late 2008 when then Senator Max Baucus, who was head of the Senate Finance Committee at the time, sort of in a prelude to the debate over Obamacare, he released a white paper on healthcare reform that actually called for eliminating the 2-year wait period for the disabled. And if you search around the Finance Committee's website, you can still find it. However, that proposal never even made it off the ground for reasons which I will come to in a bit. Now let's talk about Frank Alfisi. Frank was a senior citizen, lived in the New York City area. He was on Medicare. He had kidney failure and needed dialysis a few times a week. Now, his problems began with the way hospitals actually admit their patients. There are two ways that hospitals will admit you. They will either admit you as an inpatient, which basically means that you are fully in the hospital, or they will admit you under what's known as observation status, which basically means that the physicians, nurses, and so forth keep an eye on you and decide whether or not you need to be admitted as an inpatient or whether your problem turns out to be not that serious and they can send you home. Now enter Obamacare, which instituted a program to reduce hospital readmissions among Medicare recipients. Obamacare defines a hospital readmission as one that takes place within 30 days after the initial admission to the hospital. And Obamacare penalizes hospitals that have too many readmissions. The one glitch, so to speak, is that Medicare doesn't start counting the 30 days until the patient is actually admitted as an inpatient. So if you think about it a little bit, there's a lot of incentive for hospitals to admit more of their patients under observation status and keep them there longer. Well, the Centers for Medicare and Medicaid Services realized this and instituted what is known as the 2 midnight rule. And what this rule basically says is that if the physician determines that the patient is going to stay in the hospital at least over 2 midnights, the patient has to be admitted as an inpatient. Otherwise, if the stay is not going to require 2 midnights, then he can't be admitted as an inpatient. Now, I doubt that Frank Alfisi knew any of this when he was admitted to the hospital in mid-November of 2013. He woke up on that day. He had a scheduled appointment for dialysis, but he also had a bad case of the flu, and he decided to skip his appointment. He woke up the next day in just a terrible state. He called his daughter, Amy. She told him, look, go to the hospital. I will meet you there. We will get you dialysis. He went to St. Joseph's Hospital in Long Island, where he was going to get dialysis, but there was a problem. Under Medicare's rules, dialysis at a hospital is an inpatient procedure. But as many of you probably know, dialysis only takes a few hours. So there was no way to justify keeping him in the hospital past 2 midnights, even though he really needed dialysis. And as Amy recalled it, the physicians there actually scrambled to try to find something else that was wrong with him that could justify putting him in the hospital as an inpatient past 2 midnights. They ran a bunch of tests on him looking for some other problem, and sadly they couldn't find one. Now, eventually, the toxins in Frank's body built up to the point that his condition deteriorated, and he was going to need a stay in the hospital that was going to last much longer than 2 midnights. So he's finally admitted as an inpatient. He received dialysis, but by then the damage had been done. He was confined to a wheelchair, he needed portable oxygen, and he had lost much of his sight. In fact, a few weeks later, he lost the will to live. He asked to be moved to a hospice, but he never made it, dying in the hospital in January of 2014. Now, before we look at why some people are victims of Medicare, it helps to first look at why some people are not victims. This here is a picture of the Green Spring retirement community, which is a little over a dozen miles outside of Washington, D.C. It's a very nice place. Mom and Dad, if you want to sell your house and give my brother and I our inheritance early, this is a great place for you to move to. A few years ago, I sat down with a small group of seniors from Green Spring, and they had nothing but positive things to say about Medicare. Some of them had had heart surgery, another one a hip replacement. They were very pleased with Medicare and how Medicare had treated them, how it had paid their bills. One of them even referred to Medicare as a blessing. So why do folks at Green Spring have such different experiences with Medicare? Well, it can be traced back to the fact that Medicare policy is largely controlled by members of Congress and groups that have political power, by which I mean the ability to influence Congress, are more likely to get good treatment under Medicare. And many seniors get good treatment under Medicare because they have a lot of political power. The most important way to exercise that power is through elections. You know, the one thing that just about every member of Congress wants is to get reelected. And so Congress is going to craft Medicare policy in ways that benefit their reelection chances. As you can see here in this table, people age 65 and older have higher turnout rates than just about anyone else, especially when compared with all other citizens who are eligible to vote. There's a considerable difference during a presidential year in 2012 there. And in an off-year election, 2010, the difference becomes even greater. So they have an awful lot of power at the ballot box. Now, it also helps to look at the turnout rate at actually Green Spring, which you can do because Green Spring is actually its own polling place in the 11th Congressional District in Virginia. There are about 2,000 residents of Green Spring. And what I'm doing here with this table is showing the number of people who voted at Green Spring in the presidential election and the off-year election, and then compare it to the rest of the congressional district, most of which is Fairfax County, and just comparing the difference between the turnout difference between the two. In Green Spring, there's only a 7% difference. They put the rest of Fairfax County to shame on that. It's not a surprise then that Jerry Connolly, who represents that district, by my count, had visited Green Spring about 8 times between 2009 and 2012. In fact, when members of Congress were holding town hall meetings on Obamacare, Connolly held his town hall at Green Spring. Another advantage seniors have is that many of them live in retirement communities like Green Spring, or they belong to senior centers, which makes them relatively easy to organize should the need arise. And then finally, many of them belong to the AARP, which, as most of you know, is one of the most powerful organizations here in D.C., especially on the issue of Medicare. Now, let's compare some of this to the disabled. I was able to find one study on the voting behavior of the disabled. It looked at the election of 1998, so I don't have something a little more recent. But I doubt this has changed much in the intervening period. So with this table, looking at 1998, you can see that the disabled actually vote at rates not only lower than seniors, but lower than the total voting population as a whole. And then when it comes to the 2-year waiting period, the numbers are even worse. You know, as I mentioned earlier, only 1.2 to about 1.8 million are in the waiting period at any given time. That may seem like a lot, but when you spread it out over 435 House elections and 100 Senate elections, it's not a lot, and that's assuming that everyone who's in the waiting period votes, which of course they don't. Another disadvantage that disabled people have is that they are often quite ill, and as such, they are in no condition to be organizing, protesting, trying to get media coverage, and all the other activities that can get the attention of Congress and maybe change Medicare policy. And I think that's why the proposal by Senator Baucus to eliminate the 2-year waiting period never got off the ground. There were a lot of groups that were necessary as part of a coalition to pass Obamacare, whether it was the AARP, hospitals, physicians, and so forth. But the disabled were not essential since they don't have as much political power. And so a provision in there reducing the wait time, the 2-year waiting period, was not crucial to the passage of Obamacare. As for people like Frank Alfisi, I suspect that their political power is almost non-existent. Ask yourself, how many people do you think belong to a group that we might call harmed by Medicare's two-midnight rule? I don't really have an answer for that. What I can tell you is that Frank's daughter Amy contacted her representative, Peter King, her two senators, Charles Schumer and Kirsten Gillibrand, about her father's plight, and has received no response from any of them. I suspect if there were many, many seniors running afoul of Medicare's two-midnight rule, Congress would already be in talks about what to do about it. They would be very nervous, and Amy probably would have received a call back from at least one of her representatives, if not all of them. And of course, Frank suffers from the biggest political handicap of all, which is that he's no longer with us. Unless you are from Chicago, your vote doesn't count when you are dead. So to sum up this part, the patients who are most likely to get good treatment under Medicare are those that have political power. Medicare's victims, on the other hand, are often the sickest of patients because the sick usually lack political power. First, relatively few people get that seriously ill in any given year, too few to make much impact during election time. Second, they are seldom in much condition to be engaging in political activity. And last, some of them are so ill they won't be around for the next election. Now, before I talk about physicians, let me make a few comments about the idea of Medicare for all. Some of you may have heard of this recently. This is the way that people on the left particularly are talking about single payer now. They don't call it single payer, they call it Medicare for all. And who can blame them? Medicare is still a popular program, and if calling it Medicare for all, you might argue, is good marketing. Our good friend from Vermont, Senator Bernie Sanders, has been particularly involved in promoting Medicare for all lately. So it may be a little bit a part of this upcoming election campaign. However, one thing I never see about any proposal about Medicare for all is any explanation as to why Medicare presumably works very well. In other words, what is it about Medicare's structure that enables it to function well? And that would seem to be something that's rather useful to know, since perhaps we could transfer it or apply it to government health care programs that don't work well, like Medicaid or the Veterans Administration, so that they would improve. But in fact, to the extent that Medicare works well, it has nothing to do with its structure, but with the fact that a substantial number of its beneficiaries have political power. Again, if a lot of seniors start having trouble with Medicare, it won't take long before members of Congress hear about it and are scrambling to fix it. Unless the level of political activity of seniors can be transferred to the population at large, then Medicare for all won't work. Those with political power, such as seniors, maybe the relatively well-to-do, will get good treatment under a system of Medicare for all. Those without much political power will lose out, and as I've noted, it will be some of the sickest, those who are in most need of health care, who will suffer the most, since they are the most likely to lack political power. Okay, now let's look briefly at physicians. This here is Dr. Dariush Sagafi, along with his wife, Patricia. And he is a neurologist near Cleveland, and what makes him stand out is he actually does house calls 4 times a week. He'll often start his day at around 9 or 10 a.m. and sometimes doesn't finish until around 9 p.m. He has a lot of elderly patients on Medicare, some of them with dementia, and those patients have a hard time making it to his office. And so for that reason, he started making house calls. But as he started doing more home visits, he found that he gained a lot more information about his patients. As he said to me, quote, "You can see what may be impacting them in their dementia or chronic pain in their home environment. You find out what obstacles they face in complying with their medications. You see what risks they have in falling. Elderly people falling at home constantly. You wonder why. Well, you have throw rugs here, little coffee tables there. all sorts of fall risks for an elderly patient. I can also see how well they're moving around, if they're having trouble getting up from the toilet or trouble getting into their bed. As he put it, he says he has a bird's eye view of what's going on in their home that's contributing to their health problems. Now, his visits with his patients usually last at least an hour. I spent a day following him around, and it was common for them to last longer than that. Now, Dr. Sagaffi does earn a good living. He told me he earned about $140,000 a year. He's by no means hurting. But what's interesting is that the median salary for a neurologist is about $230,000 a year. And that puts Dr. Sagaffi in the bottom 10% of what neurologists earn. So it kind of raises the question, how is it that a physician that provides quality treatment like Dr. Sagaffi isn't paid much better? Well, in the early 1990s, Medicare instituted a new set of price controls for physicians, and the way it sets prices for physician visits had some unintended consequences, one of which is that physicians generally get paid more for spending less time with their patients. Now, in this table here, what it shows is the various types of physician visits, level 1 through level 5. Shows how much they're paid for each visit and the recommended number of minutes for each visit. Level 1 visit obviously is a very simple visit, not a very complex patient, all the way to level 5, which is with a patient that has quite a few health problems. And if you look at it here, it does kind of look as though you get paid more the more time you spend with, the physician gets paid more the more time he spends with the patient. But that's actually misleading. To get a better picture, what I did is actually divided the amount that physicians are paid for each visit by the recommended number of minutes so I could get a sense of what they were paid per minute. And in this figure here shows what they are paid per minute. And what the general trend is that the shorter visits, you actually get paid more per minute. And then as the visit goes on, the pay per minute goes down. All right. Now, there is another piece in the handout there that shows a comparison of physicians, one that does short visits, another that does long visits, and who's paid more. I'm just leaving that out for the sake of time. But you can take a look at that later if you want. But the biggest point I want to make here is that Medicare, in effect, penalizes physicians who try to provide better quality to their patients by spending more time with them. As Dr. Sagaffi told me, quote, "If I was willing to spend less time with my patients, I know I'd earn more. I've struggled with that for 10 years, but I just can't treat my patients that way." And the problem is that the research shows that patients tend to view longer visits as ones that are of higher quality, and with good reason. Other studies show that longer visits enable physicians to ask more questions and provide more information about a patient's health problem and its treatment. What we should want is that physicians like Dr. Sagaffi earn well above the median, say hypothetically $300,000 a year. The reason is that his salary would act as a signal to other physicians. They would wonder how he gets paid so well, eventually realizing that it's because he makes house calls to his patients. It wouldn't take long before other physicians, wanting to make a similar income, started making house calls for their patients as well, and the quality of medical care would improve across the board. But until we move away from a system of price controls in Medicare, that's not likely to happen. Finally, let me run through some of my suggestions for reforming Medicare. I think Medicare reform should start with the basic principle that Medicare's money should go directly into the hands of beneficiaries. That is, the beneficiaries should pay for health care directly, and they should exercise ultimate control over how Medicare funds are spent. To that end, I would get rid of Medicare Parts A and B and replace them with a system of basic accounts and major medical accounts. Now, starting with the basic accounts, each Medicare beneficiary would get $5,000 in his basic account annually. The beneficiary spends it on health care as he or she sees fit. If there is money left over in the account at the end of the year, the beneficiary gets to keep 10% of it to spend on whatever he wants. So if he, say, has $3,000 left in the account, the beneficiary keeps $300. Now, for the beneficiary who has serious medical problems and goes through that $5,000 in the basic account, he would then get access to a major medical account, which has $70,000 in it. The beneficiary gets to keep, in that account, 1% of what is left over at the end of the year. So, if he has $60,000 left over, he gets to keep $600 to spend on whatever he wishes. One of the reasons I broke it up into two accounts is because when you look at Medicare spending data, there is potentially a lot of savings to be had at the $5,000 level and below. As for the $70,000 account, that is, of course, for people with more serious problems where they need surgery or so forth. Although recent research has shown that there's probably a lot of savings to be had in that area of Medicare, the more catastrophic area as well. Now, what about people who exceed the full $75,000? Well, for the indigent, Medicare would pay for any expenses above that. For everyone else, they will have to purchase a private insurance plan to cover any expenses above the $75,000. Sort of like the way we have private Medigap plans now to cover Medicare's cost sharing. This would sort of be the new role for Medigap plans. I think these reforms have the potential to create a lot of savings for taxpayers. First, these accounts give beneficiaries incentives to watch how much health care they used, to look for the best deals on health care, and to make better and to take better care of their health. Because doing all of those means that the more money they get to keep at the end of the year. Next, these accounts will incentivize physicians and other health care providers to look for ways to lower the costs of care while also improving quality, since that will be the best way to attract patients. And I would also suggest that if this program achieves savings, some of the savings could be used to reduce the 2-year waiting period for the disabled. Finally, I think this is the best way to prevent future Medicare victims. When beneficiaries control the money, they decide what care they need, not Congress and not the bureaucrats at the Centers for Medicare and Medicaid Services. So if future Frank Alfisis need dialysis at the hospital, they get their dialysis. If they and their doctors agree that's what he needs, he doesn't have to worry about 2 midnights and all this other nonsense. He decides what treatment he needs and he gets it. In short, this reform empowers Medicare patients, which is the best way to prevent them from becoming victims. Thank you very much. Any questions?
Thank you, David. We'll take questions. Let me start off because I had a question about where you left off with Frank Alfisi. Why was it that he didn't wind up at an outpatient dialysis center? Because for example, there's one right across the other side of Union Station here.
Because his daughter Amy told me that dialysis centers will not take you when you are sick with the flu. So you have to go to the hospital. But now there's this 2 midnight rule.
Right. So then the next question is, why didn't the hospital provide it on an outpatient basis?
Under Medicare's rules, they can't. It's an inpatient procedure.
So they're not allowed to, is the issue, because they couldn't say, well, it's billed as outpatient.
No, could not bill it as outpatient.
So again, this is another thing where the logical solution for the patient is actually contravened by the regulation.
There you go.
Okay. Questions? Yes, sir.
Do you have any?
Please identify yourself, actually, if you could. We've got a microphone so that others can hear. Thank you.
Hi, Elliot Young with the Coalition to Reduce Spending. Do you have any, estimates as to the commonality of instances like Frank Alfisi? Those kinds of things, situations where that particular ailment progresses to the point of that amount of damage. It seems like someone just didn't tell the hospital, you're going to treat him now. I don't care what the regulations say. This is a life and death scenario. How often does that happen? It seems like if that is happening a lot, then the problem is much more severe than the news media might portray it as.
I would suggest to you the problem doesn't happen that often, and that may be why the news media is not covering it. I do know that other doctors, other hospitals have run into the problem, but I doubt that it's that that it is that widespread of a problem, and because of that, it's going to be very hard to make changes to the 2 midnight rule that will help people like Frank Almisi.
Thank you.
Another question?
Over there.
Over here? Yes, sir.
Yeah, I'm Sean Higgins. I'm with the Washington Examiner.
You did a good job of explaining why the issues with sort of organizing Medicare recipients and that stuff there. I'm curious to know more about organizing the physicians themselves. I mean, they obviously have more money and more means, although they're probably also equally pressed for time. But certainly every time I go to my doctor, I mean, he goes on endlessly about his issues with Medicare and what he doesn't like about it.
Well, it kind of depends on what kind of a doctor you are. I think primary care physicians have the roughest time with Medicare, although this is not to exclude specialists who can have trouble with Medicare. The reason is that there's this committee known as the Relative Value Update Committee, which advises Congress on Centers for Medicare and Medicaid Services on the Medicare's price controls. The Center for Medicare and Medicaid Services usually takes most of their recommendations. This committee, though, is dominated by specialists. There's about 5 people on there who are primary care physicians. The other 20 plus represent specialist societies. And every person who's really ever looked at the committee's dealings, and it's a little hard to find that information out because they are secret for the most part, but physicians who've later been off the committee and have fessed up have basically said that, look, the specialists try to push up the prices for procedures and things that benefit them to the expense of evaluation and management services, basically the visits, level 1 through level 5, that are the bread and butter of primary care physicians. So even within physicians, you have groups that lose out and groups that have greater amounts of power.
Do you have more questions?
I'm still curious about the midnight to midnight rule. Is that literal, seriously? Midnight to midnight, or are they saying you must be in the hospital 24 hours?
They're saying you have to be in the hospital more or less 48 hours, that you're going to cross 2 midnights, basically.
Well, that's 24 hours and 2 minutes, isn't it?
Well, yeah, technically it would be.
Well, part of this is just devil's advocate. It's essentially the thing you're discussing. It's peculiar interpretations of very odd discrepancies as to what you could argue one side or the other is what is 2 midnights versus 48 hours, and if it's 48 hours, why don't you just say 48 hours, and whatever comes into it. But because not everything's going to happen that's harmful to you overnight. Just
Sure.
when you're there, you
Sure.
need to be there for 48 hours. That's why I was just curious.
Well, it would also depend on when the patient, arrived at the hospital. To my knowledge, Frank arrived late morning, so, for him it would have been closer to probably at least 36 hours, if not that, and, plenty of time there for his kidney failure to, wreak havoc on his body, as it did.
Will Amatruda, with regard to the 2-year waiting period and the 2 midnight rule, I suppose the obtuseness of regulators can be blamed in part. But what about the role of the people who say, well, you've got to always cut federal spending, and this is one way to do it. If you're obviously going to have fewer disabled people under 65 on Medicare if you make them wait 2 years as opposed to immediately. And with regard to your proposal about, unless you're indigent, any expense over 75,000, you've got to buy private insurance. Sounds reasonable, but insurance companies can also have some maddening rules as well. And I think the best measure of that is ask people, how many people say they love their doctor as opposed to how many people say they love their health insurance company.
Couple things to take on there. You could certainly run into problems with private insurance covering above the 75,000 amount. The nice thing about the way I set it up is you're probably not going to have that many people actually hitting that ceiling anyways. The average you have. I don't even think 10% of Medicare beneficiaries have over 25,000 in expenses each year. The average was about 57,000. So. I think it would probably be fairly easy for private insurance to manage whatever is above that amount. The other part of your question was with regard to bureaucratic obtuseness. Yeah, boy.
But also insisting that spending be kept as low as possible.
Sure.
Surely that was part of the motivation for this 2-year rule.
Absolutely, that was part of it. I mean, initially the concern was what was known as crowd out. That is, would people quickly drop their private insurance to go on Medicare? There are ways now, though, I think that, given the improvement of technology, that, you could find ways for, the people who are genuinely uninsured to put them on Medicare a little bit earlier than others. In fact, there was the CBO came up with the cost for a proposal to do that. That, interestingly enough, cost about the same amount as it cost Obamacare to close the donut hole in Part D, which is now in the process of being closed. Why did that proposal, for the donut hole, make it into Obamacare and a proposal to at least reduce the waiting period not? Well, again, they needed the AARP on board. They needed seniors on board. This was a way to do it. They needed pharmaceutical makers on board. This was a way to do it. The disabled, they just were not crucial to passing that.
Sorry, jump in here, moderators. I don't know if you looked at this, David, but did you look at how this compares with private disability as well? Because I think maybe part of the explanation is for waiting period is to see, well, is this a real long-term disability or is this something short-term that somebody can go back to work? Because it was usually work-related. I mean, I know that in the private sector, that's the way it works, private disability insurance. And maybe that just got copied over. I don't know. The other thing that I thought was interesting about the context, and maybe you looked into this, on the catastrophic is that, and maybe people may not be aware of that, traditional fee-for-service Medicare doesn't have a catastrophic limit. So in effect, that's part of what seniors get when they buy Medigap, isn't it?
Yes. Yeah, I mean, with seniors by Medigap, I mean, they do have Medicare Part A, for example, has a limit on how many days you can spend in the hospital and how much of each day they'll cover, physician fees and so forth. Under Part B, they cover 80%, and Medigap covers the other 20%. As for the things on disabled, yeah, some of it is work-related, although, it covers a lot of things now that are not work-related, like kidney failure or like multiple sclerosis and so forth. Unfortunately, I didn't really dig into how private insurance and the disabled, how that works. So I'm at a loss on that one. I'm sorry.
Can't cover everything. Yes, do we have Amy?
Hi, well,
Got the microphone here.
thanks. As you know, I'm Amy Ridenauer, work at the same think tank you do. I had two questions, actually.
Sure.
One is a follow-up from the very first gentleman's question about media coverage. It strikes me, and I hadn't thought about it before, but that media coverage of Medicare is probably somewhat Immediate coverage, almost everything is pretty bad, but it's probably worse than most because the scope of Medicare is so huge, it's difficult for anybody to cover. And then when you are covering it, if you're at a local newspaper or something, you might run a story of, say, the gentleman in your book, but you're not going to run a story about like all the people like him. It's just going to be a human interest story, and then you move on to something else. So my first question is, to what extent is a difficulty in just reporting this issue keeping Congress from addressing some problems? And then my second question, and I don't even know if you've thought about this, but on the other hand, maybe you know all about it. To what extent does Medicare unnecessarily raise costs because it has rules that would prohibit innovation in such things as, does a doctor need to do this versus a physician's assistant or a nurse or a druggist? So, I mean, does Medicare artificially, particularly over the years, cost a heck of a lot more just because it's not designed for innovation, or is that not really a problem?
Regarding the first part of your question, I don't know about particularly about the media's difficulties. I can certainly tell you about my difficulties trying to find these patients. A lot of them I got, like a lot of Chapter 5 actually came from Dr. Dariush Sagafi, who said, "Are you aware about this problem in Medicare regarding physical and speech therapy?" I said, "No." The one on overtreatment, I basically had to spend hours going through LexisNexis looking for someone who had struggled with a colonoscopy, and I finally found one. They're just not reported on. There were two that I did find, but they were through local papers. One was the woman I interviewed for Part D, that was in the Daily Oklahoman. And another person who was part of Chapter 5 I found through, I think it was the Detroit Free Press, whatever one of the Detroit papers is there. So, it's difficult to find these people. And then when you do find them, it seems like no one has any actual data on how widespread the problem is. There were a couple of instances where I tried to, I couldn't in the book actually, I had no data on how widespread the problem is, so I tried to talk about it via a proxy where there was some data. As regards to whether or not Medicare actually can end up costing more because of some of these regulations, I mean, does a bear sleep in the woods? I'll give you an example. This is actually in a story that I've written that's in the Washington Examiner this week. It's actually their cover story, yay. A woman I just recently interviewed is on Social Security disability insurance. She'd very much like, and on Medicare, she'd very much like to get off and go back to work. She has this problem known as trigeminal neuralgia, which is a nerve problem in the face, causes excruciating pain, especially when it's windy and cold. And during the winter months just puts her out of action. Now, she has had an operation for it, which has helped temporarily. She's on medication for it, which sort of eases things temporarily. She has been recommended for laser treatment, which could probably provide a more long-term solution. There's two basic types of laser treatment. There's hot laser and cold laser. Well, due to an operation years earlier, she has in her ear, one of her ear bones was replaced with a metal prosthetic. And obviously, as you can guess, it's a pretty dangerous mix to have a piece of metal in your head and have, a hot laser anywhere near it. But Medicare will not pay for cold laser treatment at this point, even though the FDA has said, yes, this is viable treatment for pain management. Medicare not paying for that means the longer she's going to stay on Social Security disability insurance, the longer she's going to stay on Medicare, and the longer she's going to have health problems with her trigeminal neuralgia. And that's going to cost probably a lot more in the long run than would, getting cold laser treatment.
Think of other examples.
Oh, yeah, I'm sure there's plenty of them. Other questions?
Do you have any? I think we can wrap up then.
Wonderful.
Well, thank you very much, David. I
Thank
look
you.
forward to more from you on it. Thank you. That concludes our presentation today. And I believe there are books available outside. Yes, if you haven't got one already.
Happy to sign
Okay.
If you are nice enough to buy one, I will
I'd
be
be happy
more
enough
than
to
happy
sign
to sign it.
It's the usual author arrangement. Thank you.